I'm going to just give you a flavor of some of the things that we have found in our environmental scan in the first year about current practice. We collected data from everybody, as you can see, residents, family, physicians, personal support workers, nurses, spiritual care, social work, dietary, housekeeping, maintenance, because we feel it's the whole community that are involved. And we use many different methods, surveys, interviews, focus groups, etc., including looking at the documents. That just gives you a sense of how many people we involved and the perspectives. And you'll see there the heavy emphasis on the personal support workers. We interviewed and talked to 205 personal support workers. This first scale that I'll just show you very quickly is on organizational culture very broadly. It's called a Quality in Action Scale, developed by Dr. Ross Baker at U of T. And it measures these subscales that you can see before you. And I'm going to show you this slide, which is all of the data from all of the staff from the 4 homes. So each of those colored bars represents one of the 4 homes. So you'll see there's not huge variability between the homes, highest scores being on the perception that the organization is very patient-focused. You'll see that on the left. And on the far right, lowest score on sense of personal influence over the organization. I don't have the slides here, but you can get them on our website. There's a real discipline variability. So when you look at personal influence, that's including scores from managers and PSWs. And you can believe that the PSW scores are much, much, much lower than what you see there. We wanted to look at psychological empowerment in the workplace for personal support workers and discovered that very positively their work has great meaning, they feel competent at their work, but again you can see they feel they have very little impact on changes that they perceive need to be done, even at the bedside, because it really seems hit and miss. And then we looked at supervisory support for personal support workers, again to discover that there was quite a bit of variability here between the 4 homes in how much the PSWs felt they could rely on their supervisors to really help them out at the bedside with some of the things that they needed. PSWs talked a lot about having an internal conflict when they saw a resident where they felt they weren't comfortable, when they were dying alone. The PSWs really knew that providing comfort was their goal, and they talked very eloquently about not only needing but wanting education. And again, speaking about Robert Buckman's talk on communication, that is a huge area that all staff identified was wanting more help in having communications. Just quickly, we asked nurses about their sense of self-efficacy, their confidence in providing end-of-life care. Scores were pretty high. Then we gave them more or less an exam, the palliative care nursing quiz, and the average score was only 60% on 20 basic nursing questions that you would be expected to know. So there's a bit of a disconnect between perception of how well staff are doing and the reality, at least as measured by this quiz, you know. Some of the barriers, Kevin talked about this, hierarchical structure of the organization, challenges with communication and teamwork, staffing levels, staff always express lack of time, accountability structures, I think, that prioritize the physical care, and this cultural conflict between end-of-life and palliative care. There's a real language problem and lack of understanding between the difference between palliative and end-of-life care. And I'll just bring this up quickly because both in England and in Australia, they really talk about the difference between the palliative approach, which is more philosophical and begins much, much earlier in the care of the resident, and the end of life, which is really around the inevitability of death. And it's certainly been my experience that what is referred to as palliative care today in long-term care is really end-of-life care. And that middle piece that Robert Buckman talked about, which is the palliative piece, is not really happening. I asked the clinical managers and coordinators to help me understand what would be the residents who were palliative as opposed to end of life. And I gave them this question: would you be surprised if this person died in the next year? And I asked them to make a list. And the first thing was, it was really tough for them to do that because they don't think that way, that this is an expected death, but not an imminent death. And I asked them at the end, when they did that, to write down some of the indicators that they used to help them, because I thought that was very interesting when we begin to try to understand that transition between into that middle stage. And just so you know, 40% of the residents were included in that list of people where they would not be surprised if they would die. And that is consistent with the number of deaths they have a year. So it feels right. About 40% of their residents die each year. So what can we say about the process that we've learned? It's slow. It sure needs to be sustainable. It sure needs to build on existing resources. Each long-term care home needs to identify their priorities. And we as researchers very much work as facilitators. We're developing clinical tools, educational strategies, and helping look at policies. And the new Long-Term Care Act will help us because it does make end-of-life care a mandatory service, and it does require palliative care education. And a lot of the things that they talk about there, like pain management and wound management, are really core pieces of palliative care anyway. We're working on using the Snoozlin room, the multisensory room, more effectively for residents with dementia who are palliative. We're working on a RI-based palliative care plan, working very closely with our palliative pain and symptom consultants in Ontario, who have been just wonderful, and now working on some protocols for music. We've got a curriculum that we've been offering to PSWs, and I've got a copy of it at the NICE booth out in the foyer if you want to have a look at it. And I'm going quickly because, and we're looking at policies and procedure development around use of volunteers and grief and bereavement support for staff, and wanting to develop competencies for PSWs in the provision of palliative care. Our community partners are becoming more and more involved as we move forward, bringing in their areas of expertise. So in conclusion, creating a palliative care culture is a very complex and multifaceted process. There is no one intervention or strategy that will create change. It's got to be incremental over time. It's got to involve clinical, educational, and policy changes. And I think, though, the outcome will be, as Kevin said, a unique long-term care approach to palliative care, which I think will be a huge contribution to all of the long-term care homes in Canada and elsewhere. So visit our website, and you'll learn all about what we're doing, and please give us a call.